Good evening, everybody. Good evening, everybody. Dr. Bidyut Mukherjee here. This is live from National Institute of Homoeopathy Alumni Association. Today's CME, we have with us to inaugurate the CME, our respected director, Dr. Subash Singh of National Institute of Homeopathy. We have with us Dr. D.N. Kalyani, President, Alumni Association. And we have today's speaker, Dr. Rajiv Sarkar, already waiting in the studio, and Dr. Kumar Vivekanand. We request the studio operator to to highlight Dr. Subash Singh, sir. Good evening, Subhasda.
Good evening, Bidyut. All good?
Happy Guru Purnima.
Thank you, thank you.
You are audible, Dada.
Okay, okay. So, am I audible to everybody? Should we start?
Yes, it's going live on YouTube.
Okay, fine. Okay, thank you very much for giving me this opportunity to be a part of this second CME, which is organized by Alumni Association of NIH. I'm thankful especially to Dr. Kalyani, who is taking a leadership so that this seminar is CME is going on regularly. And thanks to Dr. Bidyut Mukherjee. Today, as I have seen, we have two of our alumni, our rather star alumni, Dr. Vivekanand and Dr. Rajiv. They are going to participate and they are going to talk about what can be how we are supposed to handle this COVID situation and what are the instructions given by Central Council of Homeopathy, of which Dr. Kumar Vivekanand is the secretary. It is a very proud privilege for me to be a part of this, and I am also equally part that our students are doing so good. Dr. Kumar Vivekanand, as we all know, that he has done his BHMS from NIH and then he has done his post graduation, and we are really happy that he is holding such a esteemed position and working so smoothly and functioning, making the CCH function so properly. And I am also proud to have with us Dr. Rajiv Sarkar, who is working in one of the public health institute in Shillong. So it will be my pleasure to be a part of it and hear what they have to say. So I won't waste much of your time. And with this, I request Dr. Bidyut Mukherjee and those who are organizing it to go on. I wish all of them a very good, my greetings and good wishes for all. Thank you so much.
Thank you for your, thank you, sir. Thank you for your encouraging words. And we like to request Dr. Kalyani to say a few words. Dr. Kalyani, sir.
We are really thankful to our director, respected director, Dr. Subash Singh, to be with us and to encourage us in all the time. In any difficulties, any necessities, always he is with us and encouraging for this continuation of CME, which has been inspired and started by Union Minister and Secretary, Joint Secretaries during the period when our new hospital building and academic building was inaugurated. So anyway, will be always at any type of help needed by NIH and director, all the alumni. And today we are able to organize this seminar by two very much known and very expert in their subjects for this current pandemic for which we have been very much disturbed. So we will be listening from them what to do, how to get ourselves ready to fight against the COVID-19.
Kalyani sir, একটু জোরে বলবেন, please speak a bit loud.
Because,
Kalyani sir, it's not audible.
yes,
Please, একটু জোরে বলুন.
do you hear me? Hello? Hello?
জোরে বলতে
Do you
হবে,
hear?
মানে খুব আস্তে আসছে.
Hello? Do you hear me?
হ্যাঁ স্যার, বলুন বলুন স্যার.
Nothing was audible before.
স্যার.
I just want to repeat again.
Yes sir.
Hello? Is it audible? Am I audible?
Yes sir, you are audible. Please continue.
Should I repeat again? Hello?
Continue karo, live streaming is going on. Continue.
This is second CME through YouTube of Alumni Association, which has been inspired and encouraged by our director, respected director Dr. Subash Singh. We are really grateful to him. All through he is encouraging us, being present and by giving different advices. This seminar was started since the day of inauguration of our new hospital building and academic building by Union Minister. And this seminar was practically started by the inspiration of Union Minister, Secretary and Joint Secretary of Ayush. Since then we are trying for this COVID situation. We have planned our seminar, live seminar in these procedures, YouTubes. So anyway, we are very much thankful to Dr. Kumar Vivekananda and Dr. Rajiv Sarkar, two brilliant alumni of NIH. They will share their experiences and basic things to fight against the COVID situation. We are really thankful to our director, Dr. Kumar Vivekananda, Dr. Rajiv Sarkar. Thank you.
Thank you sir. And we are now going to introduce to our viewers Dr. Professor Rajiv Sarkar, who has done his BHMS from NIH and he has done his masters and had done his PhD from CMC Vellore. We will learn from Rajiv epidemiological aspects and of current pandemic. Over to you, Rajiv.
Thank you, Dr. Bidyut Mukherjee, and I'd also like to take this opportunity to thank Dr. Subash Singh, Director NIH, Dr. Kalyani, Dr. Bidyut Mukherjee, and the organizers and the NIH Alumni Association for this opportunity. What I'd like to speak today is about the epidemiological aspects of COVID-19. Let me share my screen for a short presentation. Which I've titled as COVID-19 Decoding the Pandemic. The background picture is our institution, which is in Shillong, which is in the state of Meghalaya. So anybody who would want to come to Shillong, it's a nice hilly place. Once this lockdown and other things gets over, you're welcome to please come, and we'd love to host you in Shillong. I just recently joined this place. I joined early this year as an assistant professor, and I teach the Master of Public Health students here. Now, just to start off with, I would start off with a very brief background about COVID-19 and what we all know. So I'll try to make it very fast and then try to go into some of the epidemiological aspects and try to understand some of the data that comes out, some of the interpretations, which will hopefully, help us understand what is happening a bit more well. As we all know, early this year, the world was informed of an epidemic of pneumonia originating from Wuhan in China, which now we all know as the SARS-CoV-2 or COVID-19, what the disease is called. And within a span of a few months, like December is when the first cases reportedly started, and within April too, we have surpassed about 1 million of infections worldwide. This is a very short video about the spread, and we can see that from January till the end of the March, it spread from one country to about um, 180 odd countries. Currently, it is about 216 countries where the epidemic has spread, the pandemic rather, with a total case of about more than 10 million and about 500,000 confirmed deaths. Globally, if we look at the data, the highest disease burden can be seen in Americas, where it is about 5,000 per million population, followed by Europe, which is bearing the brunt of the epidemic. And then the Southeast Asian and African countries still has much lower numbers, but this is probably due to the fact that the epidemic is starting to take its foothold in these countries, rather than to do with how the epidemic is I mean, rather to do with the stage of the epidemic than anything else. As far as India is concerned, we had our first reported case on the January 30th in Kerala. Since then, we have reported more than 600,000 cases and more than 18,000 deaths, although the current ICMR Sero survey data tends to show that this 625,000 cases is probably an underreporting, given that the seroprevalence at the national level is 0.7%, which shows that the infection rates are much higher. And then also there is there is reports of some underreporting of the death, so there can be some corrections there too. But looking at the worldwide picture, we seem to do pretty well so far. A very quick discussion on the origins and the transmission, as we all know, and there are some theories that about how it started. I'm not going to go into the conspiracy theories, but at least what we know for sure is that it spilled from bats. It was a bat infection, spilled from bat to the humans, and then it started human-to-human transmission. As per the current data goes, as per the current knowledge goes, the predominant transmission mode is by droplets, by large droplets, and hence we would require some sort of a close, prolonged contact for the transmission to happen. But there could be other mode of transmission, given that it's a respiratory disease. It could be through small droplets, which can move as aerosol particles through the airborne and be airborne, and that is one of the reasons we had, the advisory for mask use has come in. And there is some evidence of transmission through fomites, like surfaces where the particle can fall, or through direct contact. Majority of the cases is considered to be mild or asymptomatic. Now, there is a fine differentiation between asymptomatic and mild infections, in the sense that a lot of the times we hear that there's a lot of asymptomatic infection, but it also says that at the time of the diagnosis or at the time of the testing, the person could be asymptomatic. But what has shown in longitudinal studies is that they develop some sort of symptoms over time. It could be very mild cough or sneeze or some slight fever, but there is some sort of symptoms. Nevertheless, majority of the patients, more than 80%, will not have any symptom or not have any discernible symptom or have very mild symptoms. Of those with symptomatic cases, approximately 40% will have a severe disease which will require oxygenation or some sort of a hospital support, and about 5% will be critically ill, requiring ventilation or ICU admission, and that is where the highest mortality is. In terms of the risks, we know now that the risk age is an independent risk factor, which means even with among people with comorbidities, if you are old older, you have a higher risk of having more severe disease and mortality, and also people with underlying medical conditions. And this is changing. This is the latest guide in the CDC website, which says that these are the following medical conditions with the highest risk: with chronic kidney disease, COPD, people who are immunocompromised because of a solid organ transplant or for other reasons, people with obesity, people with a serious heart conditions, sickle cell diseases, or type 2 diabetes mellitus. Typically, the median incubation period is 5 days, which means that from the time we get infected, it takes us about 5 days to start developing signs and symptoms of the disease, if we have the signs and symptoms of the disease. But this range is quite large. It is between 2 to 14 days, as we know, and there is again some studies which are saying that it could be longer than 14 days. Once we develop some sort of a symptom, that if it's a milder case of the disease, the symptom could be about 10 days by the time we start recovering, or it could be much longer if it is much more severe form of the disease. As we know now, that the common symptoms are cough, fever, chills, muscle pain, shortness of breath, sore throat, and loss of sense of smell. That is what is majority. Many patients are seen with fever being the commonest, but then there are some atypical presentations like diarrhea, which is also now being reported. In terms of prevention, well, the COVID-19, the disease is like a respiratory illness. So the preventions are what is typically done for any kind of a respiratory infection, which is maintain distancing, using of disposable tissues, or when you're coughing or sneezing, handkerchiefs which can then be washed or disposed of if it is disposable, wearing a face mask while in public, not touching hands, face or mouth, disinfecting surfaces to ensure that the fomite transmission is reduced. If someone is sick, the advisory is to stay at home. If someone is infected, to test positive. Also, the advisory now is quarantine, you stay at home, and then hand washing for a minimum of 20 seconds. And these are all well-known facts, so I'm not going to dwell much more into that. But what we have seen with COVID is an unprecedented situation where the entire world has kind of shut down. We have people who are staying at home for now months altogether. India is almost on the 4th month of the lockdown, and we are not seeing an end to it. And this is true of many other places. And even in some places where they have opened up, we are seeing a resurgence. And we are seeing that they are going back to, again, kind of a extreme social distancing or lockdown. The only exception probably is Sweden, which has much been talked about, that given the fact that they did not go for a lockdown, unlike other neighboring Nordic countries, and although they did follow social distancing, and there is data to show that movement of people were much less, majority of the people stayed at home. So the conditions are different, and still with that they had very high mortalities compared to the other Nordic countries. But where did this whole strategy of this lockdown, this social distancing come from? Well, if we look at the origin, it was a paper published by a group from Imperial College in London way back in March. I mean, it's a few months, but it seems way back to us now, where they had looked at different strategies, and they had modeled these different strategies using a mathematical modeling approach, which is a stochastic model is what they had used. And what their recommendation was that, and they typically looked at surge capacities, looked at whether what will happen given the information at that time if different strategies were used. And they found that although mitigation strategies such as case isolation, quarantine, social distancing, closing of schools, etc., would be of help in reducing the spread of the epidemic, but still there's a good chance that the hospital capacities will be overwhelmed in terms of the bed requirements and other things. And this was done typically for UK and US, but it is applicable to other countries as well. And they found that the only way to keep the requirements less than the available number of beds was to go for what they call as an epidemic suppression or a lockdown. And that was a recommendation which came in March. Initially, the UK government did not pay heed to the recommendation, and the cases started increasing and increasing. And then there was a lot of cases, also reports from Italy around that time, and hence there was a lot of nervousness around, and there was this decision to go for a lockdown, which India also did on the 24th of March, which was earlier on in the course of the epidemic as compared to other European countries. But this was the model, this was the publication, the paper, which actually set course for what we are doing today. Of course, there's criticism of this paper now. There's a lot of different comments that has come through. But in terms of the historical context, this was one of the groundbreaking papers for COVID-19 modeling. Now, why was this, and how? What are the principles that this follows? And this principles, and we have all been hearing about flattening of the epidemic curve, and that is exactly what they try to do in the model, to see that the healthcare system capacity is not exceeded. And this follows a very basic principle of infectious disease epidemiology, where you have the disease, you introduce it in a population which is susceptible, it spreads, it grows, and it multiplies. And over a period of time, you get more and more infected cases till a time when you have a lot of infection and then it starts dying down. And there was a very beautiful article in Washington Post, which came out a few months back around this in sometime in April, I think, where they had actually done a really good simulation. So I really encourage people. I've put the link here in the bottom of my slide. So I really encourage people to have a look at it, where they have shown in using a simulation that what happens if you let the epidemic run free, or what happens if you do different distancing using different different assumptions, not for COVID per se, but for a general simulation. And it's very beautifully depicted that how the curve really flattens. Now, when we talk about epidemic, when we talk about transmission, when we talk about epidemic curve, what we really also talk about is something in epidemiology what we call as a basic reproduction number, which is nothing but the average number of people that one person with one virus with the virus infects. So if I am infected, how many I would infect going forward, and so on and so forth. And it depends on a few factors, such as the transmission probability. If I come in contact with someone whom I can infect, who is susceptible, what is the probability that that contact will result in a transmission? The rate of contact, how many such susceptible people I come in contact with, and how long do I remain infectious, because that in turns will determine how many I could come in contact with, and the overall transmission rates. And for COVID-19, what data has shown is that the basic reproductive number, or the R naught, is about 2 to 2.5. Well, 2 to 2.5 in face value is a small number, because I am only infecting 2.5 people in my lifetime of being infected. So if I'm infected for 5 days, 10 days, if I remain not infected, actually infectious is what we use. If I'm infectious for 2 or 5 days, whatever the time duration is, I could only infect 2 to 2.5 people. What is the big deal? The big deal is when we start multiplying, we can see the growth is not linear, but what we call as an exponential growth. For example, if we introduce one infected person in a group of susceptible people, a large group of susceptible people, and if they infect 2.5 people on an average, and it takes about 5 days to infect for this infection to happen on an average. So if we say that on an average in 5 days, one person will infect 2.5 people, in 30 days time, we would get about 460 infected people, which is not a trivial number, and it grows so on and so forth. And think about 100 people doing that, and how much infections we would produce. And that is why we can see those kind of an explosive epidemic that we are seeing, or an explosive pandemic rather, that we are seeing for COVID-19, where it is spreading fast across the globe, overwhelming health systems in countries where they do not take adequate measures. Well, there is another concept in epidemiology which we use a lot, and which has been used a lot in terms of this particular pandemic. We are seeing vaccine trials happening in all places. People are talking about isolating certain high-risk groups and letting other people go on about their daily duties. And the whole premise of that is what is called as a herd immunity, which is an indirect protection offered from an infection to susceptible members when we have enough immune members in the place. So what happens is, if I am infectious individual, I'm transmitting my disease to a susceptible individual. If I reduce the number of contacts, the contact rate, then we would reduce the R naught of the epidemic, and hence the epidemic will slow down and eventually die out. And herd immunity is typically used in the context of vaccination or immunization, but it is true in the context of a prophylaxis. It is true in the context of a natural infection. It is true in any other context where we would make someone immune to the infection, or someone who would not get the infection. So in terms, when you're talking about arsenic album as a prophylaxis, it will also follow the same principle of creating a herd immunity. If we could give arsenic album to a sufficient number of people, and they become immune to the infection. And the concept is beautifully depicted here in this diagram. And you can see that if you have a few infected, everybody is susceptible over time. A lot of people will get infected. If you have a few immune, but majority are susceptible, and you introduce a few infection, still the disease will go on, and a lot of people will get infected, because an infectious person, the probability of coming in contact with susceptibility is very high. But if we have a lot of people who are immune and we introduce the infection, then the infection will die out, because the probability of coming in contact with a susceptible person is very low, and this is very intuitive. And there is a formula, a very simple formula, to calculate what is called as a herd immunity threshold, or in other words, how much of a herd immunity we need to stop the spread of the infection. In terms of COVID, if we look at a R naught of about 2.5, the herd immunity threshold comes to around 60%. In other words, we need to have 60% immune people for the infection to stop. In India, as of current scenario, ICMR did a study last month where they looked at the seroprevalence to kind of ascertain what is the level of transmission, what is the level of immunity that the population has attained, and they found that at the pan-country level, the herd immunity is only 0.73%. So we are way will take a long time for us to achieve that herd immunity. Of course, there's another thing to understand, that because the epidemic in India didn't start in all places simultaneously, it started in the major cities, in the metros, so as to say, and now it is slowly and slowly moving to smaller cities as people are traveling, as people are mixing more and more. The metros, the containment zones or the red zones would probably have a higher level of immunity in the population level, or be closer to herd immunity, or some of the containment zone may already have attained herd immunity, whereas the villages, the green zones where the infection is still either not started, or the infection is still, initially the transmission is initially happening, will have much lower immunities, and hence will take longer to attain the herd immunity. But overall, this is the general concept, and we would, given the current knowledge of an R naught of 2.5, require about 60% of the people to be immune for us to actually see the end of the pandemic, or start seeing the end of the pandemic. Now, we also have heard about a lot of terms that is currently being used, and one of the terms is what is called as a case fatality rate, or an infection fatality rate. Now, a case fatality rate or an infection fatality rate is nothing. It is by the total number of confirmed cases or total number of infections, and the numerator is the death. So number of death per 1,000 or 100 confirmed infections. But what is important to understand is that the case fatality and infection fatality rate is dependent on the testing. In other words, if we have a scenario where we have the same number of deaths, but we are only testing a small percentage of people, we will have a higher case fatality rate, or we are testing a large number of people, we will have a lower case fatality rate. And this is illustrated in this example, where we have about 10 detected cases. And if we are looking at one fatality on 10 detected cases, our CFR is 10%. But if we have 20 undetected cases and we expand our testing net, and we finally are able to detect these 20 people, our total number of infected becomes 30. With one death, for the same infection, the infection fatality rate is 3.3%. And that is what is typically now going around in the COVID literature, where we are saying that the disease is not as severe as it was thought to be when we started off, with case fatality rates of about 9% or 5%. Now it is said that if we are looking at the infection per se, given that a lot of people will have mild infections, or many of them will be asymptomatic, our actual fatality rate, and that is what we can call as in case or infection fatality rate, doesn't matter, that is interchangeable, is about less than 1%. The current consensus that I was reading earlier today is actually 0.3%, which is much lower. But then it is also important when we do these comparisons, and we always do these comparisons with different studies about the case fatality rates, and say, oh, India has 0.3%, Germany has this percent, that country has 2%. But it is also important to understand that given that the age dependence of the severity and death of this infection, the case fatality or infection fatality, whatever we can call it again, would not only depend on the testing, but it will also depend on the age structure of the population, which is beautifully depicted in this table. here, for example, this is a comparison early on during the epidemic between the case fatality rate of China and Italy. And we all know that Italy had a much higher case fatality rate. The overall case fatality rate was 7.2%, whereas the case fatality rate for China was only 2.3%. But if we break this into the different age groups, and if we compare the age specific case fatality rates, we can see that both countries, they are comparable. So what makes the difference? The difference is made by the population structure, whereas Italy had a much higher proportion of elderly people, almost 20% or more of the population in Italy was above 65 years old. China has a much larger proportion of younger population. And hence, when we compare the overall, the crude case fatality rates without taking into account the population structure, we can see that there is an apparent difference. And this was something that an exercise was done where they had looked at the different case fatality rates using the same age specific mortality rates. And they said, what will be the case fatality rate if we adjust for the population structure? And you can see with the same age specific mortality rate, for example, the case fatality for Italy will be about 2%, whereas Niger will be about 0.3%. And it is quite evident that it is quite different. And hence it is important to understand the case fatality rate, the the impact of demography, or even the impact of the proportion of population with comorbid conditions, because these are the ones which could also explain some of the differences between countries. So when we say that India is not seeing so many deaths in overall deaths, and the death rate is lower, it also has to do with the fact that only 6% to 7% of our population is elderly, whereas the majority of the population are young, who would probably have mild infections, but not have that amount of severe infections or death. However, again, in the overall volumes, given that we are a very large population, our overall volumes will always be higher, even though the rates are lower. And that is something that we need to understand and appreciate. Now we are also, this has been a question on testing and the amount of testing and how much testing needs to be done. And this was a graph which was produced, which is a beautiful graph, which actually shows that if you increase the number of testing, you get more number of, the more tests you do, then you can have the less total cases per population in general, because if you're testing 100 people, only 5 of them are positive if you test a wider net. But if you shorten the nets and only test symptomatic people or people with some sort of a severe disease, your proportion of cases and your deaths will be higher, because you are artificially increasing the probability of finding a positive case. But it also is a bit of a conundrum in our ongoing epidemic, because the number of tests, given that we are not testing anybody and everybody, we are testing only a certain number of people who have in some sort of an exposure history, some sort of a travel history. So we are doing a targeted testing. It will also be that if a particular place the epidemic is starting, we will have lower number of tests per million done. And that is something that we need to keep in mind when we interpret this graph, because if we have a country where the epidemic has progressed, where there's a lot of cases, we would also expect a lot of deaths if the cases to death proportion is similar across the board. Whereas in a country where there's much less number of cases, we will expect much less number of deaths if your denominator is a total population of 100 population. So we need to also understand in which stage of the epidemic or which stage of the pandemic the particular country or that area is for us to interpret this graph. Probably a better way of looking at it, probably a better way of interpreting is this graph, where we can look at more tests but lower percentage, and in terms of the cases and terms of the samples. For example, we can take the example of my state where I'm staying now, Meghalaya. If you look at it at the bottom on the, when you see the vertical dotted arrow, if you look just by the left of it, you can see Meghalaya, which has done much less tests than the average. But the percentage of positive cases per sample tested is also much less, which means is that the epidemic is still in its nascency in Meghalaya. It has much less number of people and who are infected, and hence the testing is less. It doesn't mean that they have tested less for whatsoever reason be it. So when we hear in discussions, when we hear in newspapers in the forum that, oh, this country is testing less than that and that country is testing less per million population, we should also take into account which stage in the pandemic that country is in. When did the pandemic start? When was the first reported case, and how was it looking? What are the total number of cases to take the to understand whether it is really low testing or is it simply because an artifact because of there is less number of cases, again considering the targeted testing approach. If we move from a targeted testing to a general testing approach, then of course that will be, interpretations will be different. Then we are also talking about a lot of a lot of tests that is out in the market, and we talk about different tests, such as we are talking about RT-PCRs, we are talking about antigen, rapid antigen tests, we are talking about antibody tests, and it is important to know that each of these tests have a specific significance, and the interpretations of positivities are different. And if we look typically at how the viral, so what happens is when we get infected, as we all know, the virus starts replicating in our body, then then there is viremia, and then the viral load starts going up to a certain point, and then the body's immune system kicks in, and then the viral load starts coming down over a period of time. And if we typically look at the different tests, and we can see the RNA, the IgM, and the IgG in terms of the sensitivities, we can see, and this was a study that was done where they looked at people at serial intervals from the onset of symptoms, and they looked at when the viral load peaks. You can see that the RNA test, which is the RT-PCR, which is what typically uses, has the highest sensitivity during the early phase of infectiousness, or within day 7 of the symptom onset, so within the first 7 days of symptom onset. And after that, the RT-PCR, because the viremia starts going down, is not that sensitive. Similarly, when we talk about serological tests such as IgM or IgG, because the IgM IgG peaks much later, they are more sensitive at a later stage, towards day 12 or day 14 of the infection, rather than on the earlier stage. So for example, if I do test someone, and we are talking about a lot of states where people are testing individuals when they come into the state, but if I'm picking up the infection on the way of my travel, on the day of my travel, if you test me by RT-PCR, if you test by these antibody tests, I would be negative, simply because I do not have enough virus for the tests to pick it up. But if you test after 7 days, I would start becoming positive. So it is a question of timing in relation to the infection that also becomes important for us to say whether a person is positive or not positive. And of course, the type of test used. And this table beautifully depicts about what is the significance of the different tests. And if you're doing this test simultaneously, and if you have one positive against two positive, what does it mean? For example, if the RT-PCR is positive, whereas the IgM or IgG, the serological tests, are negative, it means that patients are in the window period. So patients probably are somewhere around the 7th day of the infection, but hasn't gone to 13th or 14th day for IgM or IgG to kick in. So it's still early on in the infection, the patient is infectious, and that is why the RT-PCR is positive, whereas IgM and IgG is negative. On the other hand, if a serological test such as IgM, IgG is positive, but RT-PCR is negative, it means that the person has actually recovered from the infection, and the person is showing me some sort of immunity against the infection. So it is important for us when we talk about the test, when we talk about different positivities, when we hear all this, to understand this in relation to the course of the disease. For example, if a person is positive by IgM or IgG, there's no need to isolate that person. There's no need to self-quarantine that person, because the person has recovered from the infection. Probably the need for quarantine, if the person had not already been quarantined, would have been a week before. Not at that point in time, and this is what we need to understand. Whereas if a person is positive by RT-PCR, then we know that the person is infectious, the person has some viremia and viral load, and she needs to be quarantined or isolated. Well, the other thing that we have seen with this epidemic is a plethora of different models. People all talk about projections. We heard projections from different studies saying, oh, this is the impact of lockdown, 20% deaths averted, 500,000 cases averted. We hear a lot of different things. So what does this really mean? How do we make a meaningful interpretation of the models? And I will very quickly talk about 3 models, which actually has been in a lot of discussions, which was initially done, which was one of the model by the Indian Council of Medical Research, which actually looked at the early stages of the transmission in India. They modeled people movement, international flight movements, and other things, and then they came up with a range about the social distancing and other measures and testing and tracking, and said that identifying 75% asymptomatic individuals would delay the outbreak to an appreciable amount. The other model, which has been talked about a lot and has gained its own fair share of controversy, is actually a model by the Center for Disease Dynamics and Policies, CD. CDDEP, and because of the fact that the initial model predictions said that quarter to 300 to 400 million, which is a quarter of a billion people, more than a quarter of a billion people will be infected in India if nothing happened, and that was supposed to be by July. Of course, we know that it is much less than what it is, and one of the reasons could just be that we have gone into a lockdown and all with all the social distancing and other things, or it could just be that the model was plain simply wrong. Because when we talk about these kind of models, it is also important for us to understand that it is a model is nothing but a kind of a set of assumptions which they run through using different scenarios, and the type of the model, for example, whether if it's a compartmental, which is a called as a SEIR, susceptible, exposed, infected, and recovered, those kind of model could give a more broader outlook but not really a much refined estimates, whereas an agent based model or something which models individual populations would give us a much more refined estimate. Also, it is important to know that when we talk about modeling, when we talk about projections, numbers, if we are modeling for India, for example, we know that the conditions is different in different parts of India, the epidemic start is different in different parts of India. So it is very difficult to say that 500,000 people will die. Probably eventually, if it's true, then it will die, but at that point in time, within say 3 months, it will not, because the epidemic doesn't start simultaneously in all places, and it will take time to spread from one place to other. And if the model doesn't account for that, that could be a wrong projection. Similarly, it is important to understand the model assumptions. For example, we talked about our basic reproductive number, and we talked about the fact that it depends on a range of factors, such as the probability of transmission per contact rate, and the duration of infections. And if in any of the assumptions is wrong, then the model estimates can be wrong. And when you multiply these estimates with 100,000 or a million population, we can go way wrong. It can be a way overestimation or way underestimation. Similarly, if we do not take into account mixing patterns, a lot of model assumes that it's a homogeneous mixing pattern. For example, the probability of me who is sitting at home mixing with n number of people is equal to the probability of someone who is a shopkeeper who probably interacts with 100,000 people. And those are of course wrong assumptions, because especially in these situations where we have lockdowns and other things and majority are sitting at home, because those few people who are out are probably the ones who are super spreaders who could spread the epidemic far and wide. It also depends on the incubation period, duration of infectiousness, because if I'm infectious for longer time, I'm more likely to infect more people than if I'm infectious for shorter time. And all these can in turn affect how the epidemic progresses and how the estimates will look like. So, in other words, what was said by someone, that all models are wrong, but some models are useful. It is good to understand. It is good to kind of look at the model in terms of the overall patterns, but always take it with a pinch of salt, the estimates that come out of it. I think that is all what I had to say. This was kind of a very brief and broad overview. I hope I have been able to cover some of the important aspects, and I would be happy to take questions, and I'll stop my screen. Thank you very much.
Thank you, Rajiv, for your nice presentation. We'll request the audience to on their questions. We have not got the questions as such over here. Any question on the live chat in the backstage? Okay, so far no questions, Rajiv, but we'll want to hear from Dr. Kumar Vivekanand, and at the end we'll go for both of you the questions. Over to you, Dr. Kumar Vivekanand, Secretary, Central Council of Homeopathy, who will be briefing us. Kumar, please unmute yourself. Kumar, unmute, is it? No, Kumar, it's still not unmuted. I think you're. হয়েছে? স্টুডিওতে হয়েছে? Kumar, we can't hear you. Uh, you can use without the headphone, I presume. Please check it out. It's not audible. Again, it got muted, unmuted. No sound, Kumar. Kumar, can you please join with your with the same link on the mobile? That will be fine. Huh? Please rejoin. Yes, Kumar. Try to say. Uh, no, we can't hear you, Kumar. Kumar, can you join from the mobile, please? By the time Kumar is joining, Dr. Kumar is joining, we have a question from Biplab Datri for Dr. Rajiv. Once infected, is there any chance for a person for reinfection?
Right. So thank you for this question. So this question actually arose from some reports where they have from China and South Korea, where they found that people were positive for RT-PCR even after being called cured. So initially the thought was, is it truly a reinfection, or is it just because of the fact that the viral particles are still lying? The current consensus is that once you have infection, you develop immunity, and the ones that is found positive is a false positive. Because the neutralizing antibody, which is a definitive test of an active or live virus, was negative in that kind of patients. So the answer in short is that no. As of now, the understanding is once you get infected, you remain immune, at least for the immediate period of time. We really do not know how long the immunity lasts, whether it is for the rest of your life or for 1 year or 6 months. But it's not that you're not you not get it at this immediately another infection. Thank you.
Thank you, Rajiv. And there are a lot of praises for you from Dr. Shomindu Vikas Das, Dr. Partha Roy, Dr. Sanjay Sharma, Dr. Snigdha Chattopadhyay. And
Thank you very much.
There is another question to Rajiv from Dr. Gautam Ghosh. Can asymptomatic patients spread infection?
Yes. So in terms of the spread of infections, there are two things when we call asymptomatic. And again, as I mentioned, that we really do not know what is the proportion of true asymptomatics, because if you test early and find a person to be positive, but that person doesn't have signs and symptoms, doesn't mean that he or she will not develop it at a later date. And people who develop it at a later date would, at that point of testing when they are positive, will be called pre-symptomatic. So let us club asymptomatic and pre-symptomatic together. It is said that yes, there is a possibility of transmitting, although the probability of transmission is lower. But the transmission, actually, when you look at infectiousness in terms of the transmissibility, it starts approximately 12 to 48 hours before a developing of symptoms, even for symptomatic individuals. And that has been one of the challenges in containing this outbreak, because by the time we know that a person is symptomatic, he or she would already have transmitted to a few people. Unlike the SARS epidemic, where the transmissibility was after the person developed symptoms, so the person could have been isolated and the spread stopped.
There is another question from Dr. Gautam Pal.
Hmm.
As some studies stated that that ABS are not persisting more than 2.5 months, and as the virus is steady, mutating very fast, so whether effective vaccines are possible.
That is a very good question, and the frank answer is we don't know. Because when we talk about vaccine or vaccine development, we are still in a very early stage. Now, as we know that it is possible that in a vaccine, when you give that antibody and you have you give that antigen, inactivated or live attenuated, I don't know, when you give that and then you have an immune response, you can have a immune response which is not optimal, and then you give a booster dose, and then you kind of get into an optimal immune response. So we really at this point do not know whether the vaccine will elicit that immune response, number one, and number two, if it elicits that immune response, would we require a booster dose to get the optimal response for us to get for the infection to be prevented.
Thank you, Rajiv. We'll expect further questions. Those who had followed and not getting internet connectivity in between. Now let's move over to Dr. Kumar Vivekanand. I presume that Kumar, are you audible now? Please say.
I am audible, Vidyut.
Okay. Now it's over to you. Kumar Vivekanand is the Secretary of Central Council of Homeopathy, and we are proud to have our alumnus, Dr. Kumar Vivekanand, with us today. We want to learn lots from Kumar about the information. He is the liaison between common people, we homeopaths who are practicing en route, and with the government. So over to you, Kumar.
Thank you, Vidyut. I congratulate Dr. Rajiv for his nice presentation first. Very nice presentation, very elaborate epidemiological data he has presented. Once again, thank you, Dr. Rajiv. Today, my topic is basically a review of work done for prevention and treatment of COVID-19. Basically, what central government or central agency has done in this 3 or 4 months duration, that I will summarize all these things, and what CCH has done or is planning to do for COVID patient or for prevention or treatment of COVID-19 during these days. First of all, I must say that Ministry of Ayush is very active during these days, along with Ministry of Health and Family Welfare, and they are generating more and more manpower to to suffice the COVID warriors. Number of COVID warriors, basically, when you see in the COVID treatment center, more or less maximum Ayush doctors will be there in front line. So basically, central government or Ministry of Ayush is advisory in nature, and they have created many awareness campaigns through digital leaflets, flyers, and advisory meetings to challenge the rising out of spread of coronavirus in India. They have issued many guidelines for practitioners for different Ayush system, for naturopathy, Siddha, Unani, Ayurveda, Yoga, and in particular homeopathy. Ministry of Ayush has also expedited the process of grant of approval, license, renewal of license for manufacturing units in for Ayurveda system, Siddha system, Unani and homeopathy for immunity boosting healthcare products and sanitizers. Wherever in India there is mismanagement or misguided advertisement, Ministry of Ayush came forward to oppose all these misadvertisement. During these days, Ministry of Ayush developed advisory for human resource management for COVID-19. From March 24th, there was a complete lockdown in India, and on 4th April, Ministry of Ayush arranged a training program for COVID warriors, including all the homeopathy college, Ayurveda college, Unani college, and all state stakeholders like from health secretaries and district health secretaries, principal health secretaries from uh, all over the India. And in terms of that, they trained all other subordinates from their college, intern, PG student, and medical officers in their state. And till date, more than 80,000 COVID warriors are trained COVID warriors, and they are uh, deputed in COVID centers. Apart from this, Ministry of Ayush, they promoted Ayush research and interdisciplinary task force for Ayush clinical studies in COVID-19. This Ministry of Ayush, they work through Central Council for Research in Homeopathy, in homeopathic research, and in education field through CCH, Central Council for Homeopathy. And CCRH, during these days, they also distributed arsenic through all their units and created awareness through campaign, digital leaflets and flyers, etc. They published fact sheet regarding homeopathic perspective in COVID-19 coronavirus infection. Regarding coronavirus preventive and prophylactic, they advocate arsenic 30 homeopathic medicine for distribution, for prevention, and even for treatment of this coronavirus disease. CCRH published a special issue in their peer-reviewed journal IJRH in view of ongoing pandemic of corona disease. Apart from this, clinical research studies for homeopathy has been taken by the Central Council for Research in Homeopathy as add-on therapy in case of COVID-19. Now come to Central Council of Homeopathy. Central Council of Homeopathy, they are promoting homeopathy institutions for awareness campaign through digital leaflets, flyers, etc. They prepared telemedicine practice guideline through amendment in homeopathic regulation 1982. Though this amendment did not take place, but this guideline has been published and distributed all over the college and in all states for compliance. Regarding regular payment to their employees of the government college and private college during these 3 months or 4 months, advisory has been issued to all homeopathic, private homeopathic and government-aided homeopathic institutions for release of regular payment to their employees. During this lockdown period, guideline has been issued for undergraduate and postgraduate examination to all universities. Apart from this, now central government is planning to collect more than 5 lakhs data of homeopathic prevention medicine that has been distributed to all over India to analyze all this data in a bigger manner. Now, regarding telemedicine guideline, this guideline has been issued. This guideline has been issued in the wake of this current pandemic, where tele consultation is very limited. India's digital health policy advocates use of digital tools for improving the efficacy and outcome of healthcare system significantly. But in spite of these policies, till now there is no legislation or guideline for homeopathic practitioners on practice of telemedicine through video, phone, and internet-based platforms. Lack of clear guidelines has created significant ambiguity for registered homeopathic practitioners, raising doubts on practice of telemedicine. Nowadays, it is a new normal, which is going to remain for more than 6 months or 1 year or even more. And during these days, telemedicine will help a lot. In India, practice of homeopathic medicine is mainly governed by Concerned State Act along with Homeopathic Central Council Act 1973, Homeopathic Practitioners Regulation 1982, Drug and Cosmetic Act, and Clinical Establishment Act 2010. Apart from this, information technology is governed by IT Act 2000 and IT Act Rule 2011. Gaps in regulation and uncertainty of rules force a risk for both the doctors and their patients. It is the need of our to bridge the gap in legislation and the uncertainty of rules. To bridge this gap, CCH came with this legislation or this guideline and issued on 10th April 2020 this year. The purpose of this guideline is to enable homeopathic practitioners to use telemedicine tools. This will be done by providing information as well as training, which will be updated from time to time in the coming years. Telemedicine will continue to grow and be adopted by more healthcare practitioners and patients in a wide variety of forms. These guidelines will give practical advice to registered homeopathic practitioners regarding telemedicine to encourage them to consider the use of telemedicine as part of their normal practice, as well as in disasters and pandemics which pose unique challenges to provide health care without compromising homeopathic principles. Practice of telemedicine can prevent transmission of infectious disease, reducing the risk to both doctors and patients by avoiding social contact. These guidelines will provide norms and protocols relating to doctor-patient relationship, issues of liability and negligence, evaluation, management and treatment, informed consent, continuity of care, referral for emergency services, medical records, privacy and security of patient records, and exchange of information, describing reimbursement, health education, counseling, etc. This will not increase social distancing in special situation of epidemics only, but talking to doctors will also allay their anxiety in the situation of complete lockdown. And this telemedicine guideline or telemedicine, what World Health Organization says about it, it is the delivery of healthcare service where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and the continuing education of healthcare workers with the aim of advancing the health of individuals and communities. Advantage of this telemedicine is it provides patient safety as well as doctor and health workers safety, especially in situations where there is a risk of contagious infections. A telemedicine visit can be conducted without exposing staff to virus infection at the time of such outbreaks. It provides rapid access to medical practitioners who may not be available in person. Telemedicine will not only encourage social distancing in special situations of epidemics and pandemics, but talking to doctors also allay their anxiety in situation of complete lockdown. I said earlier, with telemedicine, there is a higher likelihood of maintenance of records and documentation. Written documentation increases legal protection of doctors as well as patients. Telemedicine, when effectively used, reduces the burden on secondary healthcare system. Telemedicine is useful for regular routine checkup on continuous monitoring and minimizes gaps in timely follow-up. These are the basic uh, scope and advantage of telemedicine, and this guideline in brief, it contains different technologies, details of technologies used for communication, that is via video, audio, text, etc. And as we are using different mode of tools, and so there is different disadvantage or limitation of uh, it having. For example, it it is dependent on high quality internet connection at both ends. Since there is possibility of abuse, misuse, ensuring privacy of patients in video consults is extremely important. Not suitable for conditions that requires a visual inspection, for example, skin, eye, or tongue examination, or physical touch, where it is required to have physical touch. Uh, that is, it is the limitation. Patient's identification needs to be clearer, greater chance of imposter representing the real patient. Beside the visual and physical touch, text-based interaction also meets the verbal cues. Difficult to establish rapport with the patient, cannot be sure of identity of the doctors or the patient. And apart from this technology used for communication, and this guideline includes guidelines for specific elements like appropriateness of telemedicine, identification of registered homeopathic practitioners, patient consent, patient evaluation, types of consultation, patient management, health education, counseling, and medication. Duties, responsibilities of registered homeopathic practitioners, along with medical ethics, data privacy and confidentiality, documentation and digital records of consultation, fee for telemedicine, and framework for telemedicine, patient to registered homeopathic practitioners, caregiver to registered homeopathic practitioners, patient to registered homeopathic practitioners, to health workers at a sub-center or any peripheral center. These are the basic things which is in this guideline. And another special responsibilities of CCH regarding this guideline, that need to be it is required to be in time bound manner. In future, we have responsibility to add some list of drugs for telemedicine, means which are the medicine which we can use during telemedicine. The list is not included in this guideline. It is the task of ourselves to have a list of this telemedicine, and in future we may amend this telemedicine guideline for wider application or wider use of homeopathic practitioners. And for this we may require some suggestions from homeopathic practitioners. So how to improve this guideline, or how to issue necessary direction or advisories or clarification in this regard from time to time. These are the basic things regarding telemedicine guideline, and it is a 35-page document, and I hope or I wish every practitioner should go through it and have a look, and if required you may use it in your practice. With these words I conclude here. Thank you. Thank you, Vidyut.
Thank you, Kumar. There are a lot of questions coming for you. But before that, let me take on the question, last question addressed to Rajiv. It has been from Dr. Snigdha Chattopadhyay. What is the duration of home quarantine for asymptomatic cases? Is it from the date of positive test report?
Well, the duration of home quarantine, initially they said 14 days, but I think the guidelines are changing. Really not sure about the current guidelines. Probably someone who is in the health system will probably know better than me. So I will not get there. But I can answer one thing from the epidemiological perspective again. See, the challenge is that ideally what we want to know is we want to know from the time the person got infected. Now that is a black box because we do not know when the transmission happened. Usually when we are talking about close contacts with a respiratory virus, given that there is a 2 to 14 days average of 5 days incubation, uh, it can happen at any point in time. So ideally, although we would like to separate them from the, at least from the time before the time they got infectious, it is not possible. So for here it will be from the time of the testing, because that is when we know that the person is infected, uh, in the truest sense of term. Again, a person can remain infectious, and when we talk about these dates, like 5 days or 15 days, we are talking about a point, about a number which is not entirely accurate, in a way that there is always a range when you talk about epidemiology or numbers, because different people behave in different ways, so that's where we call things like minimum, maximum confidence interval, and those things come in. So it is good, it is, if possible, it is always good to test and see if the person is negative, or at least clinically ensure that the person doesn't have symptoms, even if the person is mildly infected, before the person can be considered that the person is disease free and go in. So these are the things that we also need to keep in mind when sometimes we don't, given that we always talk about a point number. Like I can say 10 days that the person remains infectious, but 10 days is actually an average. Some person can stop being infectious in 7 days, whereas some person can remain infectious as long as 13 to 15 days. Depends on the range actually. So I hope I have answered, I've been able to answer a part of this question. I'm sure it's not the exact
Mic
answer.
Thank you, Rajiv. We have two more questions here before we move on
Mhm.
to Kumar for the answer. One is from Dr. Samir Manna. Is there any chance of vertical transmission?
Answer is I don't know. I have to check the literature. I don't know. Given again that this is a respiratory virus, the chances of a vertical transmission, which typically is because of a bloodborne, any kind of a bloodborne transmission, should be low. But again, I don't know, because if the viremia goes to the blood, again, it could probably have the risk. But
Okay,
yeah.
thank you. And the addition from Dr. Prita Mehra would like to know if one patient was tested positive through RT-PCR and after 14 days again he was tested positive. He is asymptomatic now. Shall he go for IgG or IgM test? Was RT-PCR gave false positive result?
So there are two things to this, and that is something that we need to think through when we talk about this testing. If a person is asymptomatic but still has an RT-PCR positive, one scenario is that the person still has infection, but the person is recovering from the infection but still is infectious. The other thing is, as was mentioned, as I had also mentioned it to the response to one of the questions earlier, that the person, it could just be that the person is no longer infectious, and it is just an artifact. There's some viral particles there which the RT-PCR is picking up, so it is a false positive. Now, one of the things that is important to know is when we talk about infection, it is, a person can be infected, a person can get that infection, but the person may not transmit the infection to another person. So that is why we use the term infectious, is in terms of the transmission to another person. Now when I have got infected, from the current knowledge that we know, I will probably not get the disease again. So I would either recover, or I'd become serious, or I would die. One of these outcomes will happen. But the reason for this home quarantine, home isolation, is that I do not infect someone who could get infected. So the infectiousness comes in. And that is where we talk about these testings, and you have to have a positive or a negative test to be able to go. So if there is an IgM response, and if there is an IgG response which comes much later, we could more or less safely assume probably that the person is a false positive RT-PCR and the person is no longer infectious. Although, as I said, as I had mentioned earlier, probably a confirmatory test would be something like a neutralizing antibody, which would show if the person has active virus particles or not. Whereas if the person has just an IgM response and still has a good viral load, it could be that the person is still positive. So the answer in a way is yes or no. Both things could be possible. Both options could be possible, and it has to be decided on a case basis.
Thank you so much, Rajiv, for your valuable inputs, and I
Thank you.
our
Sorry, Bidyut,
audience.
there is no straightforward answer for a lot of the questions. Unfortunately, that is where we are with this
Right.
pandemic.
Yeah, we understand that. Thank you. Now let's move on to Dr. Kumar Vivekanand. Kumar, there are a few questions for you. First, to start with, from Dr. Subrata Das, why COVID-19 treatment is not carried out in Ayush Hospital and other homeopathic hospitals of West Bengal to be put more forward, apart from few specific hospitals in India, why COVID-19 treatment is not carried out in Ayush hospitals? Vivekanand.
No, Ayush Hospital has been given chance to carry out this COVID treatment in Agra. One homeopathic college is there. They are they are taking homeopathic trial on Ayush in means COVID patient there. They got permission from Ministry of Ayush and CCRH to take treatment or trial on COVID patient there. In many part of India, in Maharashtra, in Haryana also, their homeopathic hospital has been taken by the state government for COVID patient. We cannot say that means it is not uh, taken by the government for treatment. And basically, it is the state subject, so they are responsible. Or but in other state also, means uh, in Gujarat, and like I told earlier, in Haryana also, in Maharashtra, all Ayush hospitals are being taken by the state government. Hello.
Ah, thank you for your answer. But actually, there are a lot of queries to be attended among the Bengal and other state people, that why
Uh,
their local hospitals are not been allowed. Anyway, let's move on to the next question from Dr. Rajat Kumar Pal. It's a very pertinent and valid question for you, being a secretary of CCH. How many months arsenic album 30 consecutive 3 days can be advocated as immune boosting? And here's another question. Any further advisory are waiting to be released in near future regarding immune boosting treatment?
no, no, the actually it is arsenic 30 consecutive days in uh, in every month for 2 months or 3 months. It is not given by the council. Just they have released that 3 consecutive day you will have to take arsenic 30 every month, and that at present I cannot say for how many months it is to be taken. Actually, it is decided by CCRH, and will have will get back from CCRH only. And
Okay.
actually, it is a policy decision. So, not more than this I can tell here.
Okay, that is understandable. We are not going to pursue further on this. There is another pertinent question from Dr. Subrata Das. Are homeopathic medical practitioners, HMO and GPMO, eligible for COVID-19 insurance?
Uh,
Kumar,
once again,
you can see it on your screen also. Homeopathic medical officers and GPMO eligible for the COVID-19 insurance?
yes, yes, yes. All Ayush practitioners are eligible for COVID-19 insurance.
Subrata had got his
All
answer.
COVID warriors or COVID 19 eligible for COVID-19 insurance. There is a circular for homeopathic doctors also. They are eligible for COVID-19 insurance. One circular is there. One means one circular of Government of India is there. They are eligible for that.
Okay, Dr. Kumar, if you could share the circular, if it's not within the means if it's within the policy to
Sure,
share
sure,
it,
sure.
we'll
Maybe
be publishing it on the YouTube channel once the recorded version is published.
okay.
If we get it from you through WhatsApp, I'll publish it on the YouTube channel through. And
Sure, sure.
next question to Dr. Kumar. On the
Hmm.
administrative part, this is from Dr. S. Kundu of Bardhaman Homeopathic Medical College. Different homeopathic company advertised to take arsenic album 30, 3 to 5 drops daily. Is it the Ayush guideline? If not, what or why they do so? It's a very common thing. We are seeing it on the social media also, like companies like Dr. Reckweig and others. They are printing it and saying it's a Ayush Ministry guidelines. Ourselves 33 to 5 drops daily.
No, means it is not the guideline of central government, and in many part government is giving direction not to put all this type of advertisement. And few days back we sued one of practitioners in Gujarat, and we have written a letter to the state council of Gujarat to back their registration number, or to delete all this type of advertisement from YouTube channel and from social media. Whatever this type of, if this type of advertisement comes to our knowledge, we are taking action, or we are taking whatever suitable action is required, we are taking.
Okay, that's so nice that you are all actively tackling this condition. And in this vast populated country of our mother India, it's a very tough job which you have to handle. Dr. Sanjay Sharma, there was a question, any guideline for private practitioner? We didn't get the question properly. I think you got your answer through Dr. Kumar's presentation relating to COVID-19 treatment as well as other paraphernalia for telemedicine. Now, next question, Kumar, is from Dr. Snigdha Chattopadhyay. What is the feedback of administration of arsenic album 30 to the population after 2 months? To be more precise, Kumar, it's almost 100 days past. We are on lockdown. We, as private
Very,
practitioners, have to face this question at present.
very encouraging result, and you will see after some days when we will collect all more than 5 lakhs data of arsenic given population. means all 5 lakhs data will be analyzed. In few days, after few days, you will get the result of that arsenic.
We are expecting some very encouraging results on
Yes,
today's panel discussion. That much we can quote, Kumar, and we are hoping to get feedback from CCH, CCRH, or Ayush Ministry in coming few weeks.
sure.
There is another question, Kumar, from Dr. Samit Hajra. Is there any thinking on the part of CCH to integrate experience, expertise from frontline COVID-19 workers from Ayush in state or central healthcare system? I think the question is very pertinent to the present situation. Kumar, did you get the question?
Yes, yes.
Okay, your
Actually,
answer, please.
it is uh, it does not come under the domain of CCH, and maybe CCRH is willing to take or integrate experience from the frontline COVID warriors, or because all 29-30 units of CCRH is actively participating in this pandemic, and they are direct in touch with CCRH, and they will take experience, or they will have first hand experience, and they must be using that experience in further policy making, or any decision in this regard if required. CCH is very less involved in this regard. So at present,
Okay.
CCH is not taking any cognizance of these frontline warriors.
Okay, but Kumar, there has been a lot of expectation, and we understand the work pressure which is going on down the line. Uh, and we are also thanking you for your availability today. And in the coming days, what we are
I
planning, Kumar, just to inform you that we have in NIH students from Sri Lanka and students from Nepal, alumni. So probably on 19th, we may have another CME, how those two countries are faring with homeopathy. And we will be expecting your presence also, being a secretary of CCH. And if you can suggest some of our alumni who are now with CCRH, who can highlight from their perspective on the updates.
so
Okay, and now I'll request Dr. Kalyani sir to sum up today's event.
Many thanks to all of you. Special thanks to our director, Dr. Rajiv Sarkar and Dr. Kumar Vivekanand, for presenting their items very nicely. Many things we were not knowing about, and we are waiting to know regarding government decisions that we have come to know from Dr. Vivekanand, and a nice presentation by Dr. Rajiv Sarkar. I think every one of us has been encouraged. Now, I must convey special thanks from all of you and me to Dr. Bidyut Mukherjee. You might not be knowing that whole the situation, what you are seeing here, is the strain or outcome from Dr. Mukherjee and his son. We are really thankful to both of them. Anyway, this is a scope maybe COVID-19 has given us to extend our CMEs from NIH campus to all over India and abroad. Gradually, NIH is taking expansion. Now SAARC countries and expecting it will expand further. What we have to do through these CME exchanges of ideas, we must show the IS government, your IS ministry, NIH, alumni, and whole countrymen as a whole that homeopathy is progressing, homeopathy is growing. So our new ideas, new concept, new thinking should be shared to every one of us. This is my heartiest request to all the alumni. Please send the name and telephone numbers to whom you want to listen, from whom we can be enriched our knowledges. So many thanks to all of you to be present over here. And I think all of you must try to be present in the seminar as a speaker gradually. Thank you all. Expecting better CMEs in near future.
Just to interrupt you, there are two more questions which have been presented. One is from Kamalesh Sharma. This question is for Kumar Vivekanand. Is there any thinking? Is there any thinking of preparation of any kind of nosol? You have any information, Kumar, from CCRH?
Uh, they are trying, but not sure about that. They are preparing something, but not sure that they are preparing nosod or COVID nosod like this. We are not. I am not sure about this, so cannot say at this moment.
And another question from Dr. Rajat Pal. Is there any opportunity to publish advisory regarding permission to treat by homeopathic medicines COVID patient? This is a question for from all over the homeopathic fraternity, Kumar. This is a question for me also. Whether any proper guidelines, any advisory?
Actually, means actually nowadays we are not thinking, but as you suggest, now we will think about this advisory, and in coming days, in 9th of this July and 15th of this July also, we have some meeting with our board members, so we can take it forward to them, and if required, we will publish all this type of advisory for our homeopathic doctors. Otherwise, they can treat patient as per their convenience, or if any cough, fever, or this type of patient comes, they can treat. Suppose any patient comes without COVID positive, or without uh, any means COVID testing, they can treat as usual as they treat, or as they means come to the homeopathic practitioners.
Okay, thank you very much. Over to Kalyani sir to conclude the part. Will not take any further questions. Thanking both the speakers. Over to you, Kalyani sir, to conclude the seminar today. Kalyani sir. Okay, Kalyani sir probably has got disconnected. Now we'll be having another session this month. We are expecting to integrate. Now over to you, Kalyani sir.
Hello. Do you hear me? Hello.
Yes, sir, we can hear you. Bolun.
Do you hear me?
হ্যাঁ শোনা যাচ্ছে? Yes sir, we can hear you.
Hello. Hello.
হ্যাঁ বলুন স্যার। শোনা যাচ্ছে? আপনার ফোন আসছে।
একটু 10টায় পরে করুন। Do you hear me?
Yes sir, we can hear you.
Just a minute, because this telephone.
Oh, sir got disconnected again. Anyway, just to conclude the meeting today, we like to thank all the speakers, and in the coming days, we are trying to have 2 more countries integrated. We are trying to have 2 more countries integrated with our CME. Now, Kalyani sir is getting the connection back again. Over to you, Kalyani sir.
I'm very sorry, my phone is disturbing me very much. Anyway, again I am conveying my heartiest thank to all of you. Please come forward with your article subjects, presentable cases, to encourage all of us and to extend this CME to the extent that everyone must be eager and they must be craving for this seminar. Please try to make it for our own, because the more we will grow, the more homeopathy will grow. And I think you will agree with me that it is NIH only in the whole world which can guide homeopathy system for the benefit of humanity. So be tone up and try to help one and each other. Means you share your ideas to us, we will share our ideas, our experiences to you. Likewise, we all of us will try to grow all together to improve homeopathy and to make NIH products as brilliant of the world. Thank you very much.
Good night to all. Kumar is there. Rajiv is there. Is Rajiv in the screen now? Yeah. Thanks all and good night. All of us, let's say good night to the viewers who had been watching the entire session of 1 hour 40 minutes on YouTube Live.
Thank you, Kalyani sir. Thank you, Bidyut.
Thank you, sir. Good night.
Good night.
Good night.
Good night.
Thank you all for watching our live stream. I hope you all guys have enjoyed this today's live stream, and I expect to make sure that you all guys subscribe to this channel to get more and more videos like this. And as per the dates announced by our host, we will be having our live 2 on 15th July, 15th date. I don't know exact, but I will mention it on the schedule. And don't forget to subscribe and click on the notification bell. just to get updated on the upcoming CME sessions. And thank you to all the peoples who have watched this until now. It's 9:41, and I'm glad that everyone still are watching this till the end. Thank you. Good night, all. Jai Hind.